Welcome to the next episode of Endoscopy Essentials. It's a very special one because we're going into the ERCP area. A very warm welcome to my old friend Nagi Reddy. Welcome.
Thank you, Thomas. I think ERCP is an area which came as one of the early ones for therapeutic endoscopy and still remain relevant. It's very important to know the technique of ERCP because the complication rates can be catastrophic.
Absolutely. Nagi, the problem I have with you is when I'm watching you during live demos, it always looks so easy. So please tell us also about the difficulties. And my first question is a logistical one. What do you need depending on the indication on prior diagnostics?
Yeah, I think the most important thing in ERCP is the right indication. Most complications occur in patients in whom the indication is not right. For example, if you have a patient who has a doubtful CBD stones, non-dilated bile duct, a female patient, your chance of producing pancreatitis is 40%. So if we take the right indications, say the obvious presence of a choledochal lithiasis, an obstructive jaundice because of a malignant obstruction which requires to be drained and so on, then your chances of a complication comes down. So I think the first important thing when you're doing ERCP is to look at the right indication. The second thing is preparation of the patients. It's very important in this era to look carefully whether the patients are using any antiplatelets or anticoagulants, because nowadays a lot of patients have cardiac problems and so on, and so these drugs should not be used. Of course, we also get a clearance from anesthetic doctors to see that they don't have any contraindications for anesthesia. Generally, we use propofol anesthesia in these patients, which is a conscious anesthesia, and the patients in our unit are put on left lateral position to start off and then are prone when we actually do the procedure. There are units which do supine. I think both have similar results. The only problem when you're doing prone versus supine is that when you're doing these patients in a supine position, you have to turn your whole body to the other side and look at the monitor opposite the patient. And second, there's a lot of pooling of secretions of blood on the papilla, so it makes it more difficult. But for the anesthetist, when they intubate, supine is better. In our unit, we don't intubate, so I would prefer to do it in a prone position.
Which might also be safer a little bit for the patient.
I believe prone position, but if the anesthetist, when they intubate the patient, feel that it's safer to do.
But I also wanted to know which type of other imaging you want to have. So like if it's a stone and the suspicion is not high, do you always do EOS or is an MRCP enough?
So if it's a high-risk stone, for example, I think an ultrasound and an abdominal LFT is enough. But in those who have moderate risk or low risk, we would like to do, nowadays we prefer to do an endoscopic ultrasound, because if the stone is 6 millimeters or less, the chance of missing it in MRCP is there. But if you look at the other indication, for example, hilar malignancy, we would never do an ERCP without actually doing an MRCP to give us a GPS of what's happening in intrahepatic ducts. So I think it's very important to know what the indication are and then decide what you want. So it could be simple ultrasound, abdominal LFT, it could be an endoscopic ultrasound in a doubtful case of bile duct stones, or it could be an MRCP in malignant obstruction, especially if you're looking at hilar strictures.
I think it's a daily problem. Patients are referred for ERCP, and I think the most important thing sometimes is not to do the ERCP right away.
Yeah.
Check whether they have imaging, and if not, repeat the imaging, especially in hilar lesions. So I absolutely agree, because ERCP is not diagnostic anymore. Okay, so we have clarified this, Nagi, and then we go down to the duodenum. How should the papilla be positioned, and where do you cannulate? And please tell us.
So of course, the first important thing is to use a side wing scope. And anybody who's starting ERCP should get familiar of passing a side wing scope down into the duodenum at least 10 cases before they actually start the cannulation. The art of passing a side wing scope is a little different from what you do with a regular end wing endoscope. The two areas which are difficult, first is when you come across the pyloric region. So we have a tendency as endoscopists to see the pyloric region and push your scope through. But when you do this, what happens is it retroverts into the fundus. So what we do is when you go to the pyloric region, we straighten the scope to go down to the duodenum. The second important area is to actually shorten the scope, and I'll show you the technique how this should be done. I think it's very important to shorten your scope. What happens is when you do an ERCP normally, this is what happens. You push your scope through, and this is called the so-called long groove position. That is the scope in the belly along the greater curve of the stomach. And when you look at the papilla in these cases, you can see the papilla comes to the right and is not so easy to palpate. Then when you come to the short loop position, the technique is to turn your scope to the right and pull back, and then you'll immediately find the scope actually progresses down. And when it progresses down, the papilla comes in optimum position, which should be about 1 or 2 centimeters below the 12 o'clock position. And this is the way you position your papilla, because then you can actually pass your sphincterotome or whatever it is in the right direction. In most endoscopes, whatever company you take, actually the sphincterotome when the elevator passes right from around 5 o'clock position towards the midline. So this is what you have to keep in mind. You're going from 5 o'clock towards midline. But it's important to position in a proper way, because if you look at the papilla now, there are different types of papilla. Every papilla is different. And that's the reason why ERCP can be difficult or very easy sometimes. When you get your papilla straight on, like in this case, it becomes very easy. But if it's on the side, like in this case, and you can't shorten your scope, then it becomes difficult. So the most important technique the first important technique in my view is to position your papilla properly, and for that you have to do a shortening of the scope, get your papilla just below the 12 o'clock position, and then you're ready for the cannulation.
So that means in the middle of the picture,
yes,
2 centimeters below 12 o'clock. How
1
close?
to 2 centimeters.
Yes, 1 to 2 centimeters below 12 o'clock. How close you should come to the papilla?
I think you should be, when you do the initial cannulation, one of the mistakes people make is to get too close to the papilla. You should be in a very comfortable distance away from the papilla, so you have enough space to actually put your sphincterotome inside and then position it in the right way. So I think it's important to be away from the papilla initially. The only time you get close to the papilla is when you want to pass a big accessories, and we'll come to that a little later, either stenting or cholangioscope and so on.
And if we look at those other difficult positions, what do you do? So you try several maneuvers to bring the papilla into the position in the low picture in the center, right?
Yeah. So what we would do is that if you have a papilla, say for example in a long route like this, we'll have to push our scope really down into the third part of the duodenum and then reduce it. And sometimes you can then get a good position, which can be unstable. The way to stabilize your scope in an unstable position is to turn your body to the left, and then when you turn your body to the left, the scope becomes stable. So this would be the way. Whatever it is, you have to get your papilla en face, otherwise it's very difficult to cannulate the papilla.
And also sometimes in the long scope position, if there's no other way.
Rarely we have to do it in this long scope because you can't shorten. This happens sometimes in patients with, say, infiltrative tumor of the duodenum, where the duodenum gets fixed, so you can't actually shorten it, and it's dangerous to shorten it at that point of time. So rare occasions we do on long position, but it's important that when you do in the long position, once you pass your accessories, you can actually shorten the scope again.
Does the stomach have any influence if it's overinflated?
Yeah, I think this is also important. If you're doing a procedure for a long period of time, of course we now use carbon dioxide, even then the stomach can get inflated. It may be worthwhile to go back into the stomach, aspirate all the air, and then go in again.
Okay, when the papilla is a little bit to the side, can you bring it back by hooking into the orifice and then moving, or is that...
No, we can't do that. Actually, you hook, but then you have to get significantly deep inside, especially into the bile duct, to do this. And there are also sphincterotomes that are now available, which can be twisted from the handle. So you can turn the sphincterotome to the left or to the right.
Okay, so we have the papilla in a decent position. What's next?
And next, of course, is the ultimate end point of any ERCP is selective cannulation of the duct. Now, selective cannulation of the duct can be done by different techniques. The technique that used to be used long back when actually ERCP started, we're using these cannulas. We no longer use them. The only indication I use the cannula is two. One is in patients with a Billroth 2 or a post-surgical patient, surgically altered anatomy, when the papilla is looking down. or I use it sometimes for a minor papilla, rarely. Otherwise, I don't use them. So
Because it's coming out straight and
it's coming
not
out straight
going
and
into the right
because
direction.
a sphincterotome is actually a catheter which can be moved, so you have an advantage of moving it. So there are a variety of sphincterotomes that are now available from different companies. Some of them are dome shaped like this, and then some of them are more tapered. But whatever sphincterotome you use, you have a wire here which you can manipulate. You can actually flex the sphincterotome to get into the direct position. So this is very important.
One other question, there used to be two schools. One school said that you should inject first and then cannulate, and the other school says try to cannulate first and then inject.
Yeah.
What do you think?
We'll show you some of the techniques here. My own feeling is that one should not be absolute. The wire guided doesn't mean only wire all the time. Injecting contrast doesn't mean only injecting contrast all the time. Actually, it's usually a mixture of both, and I'll show you examples also. The first approach would be to pass a hydrophilic guide wire and try and get inside the papilla, and then see if you can get into the selective duct you want to. If you can't, then of course you can inject a small amount of contrast, because the lower end of the papilla the lower end of the CBD can have an S shape, and going through may be difficult. When you inject cannula, you get a pathway, and inject some contrast, you get a pathway, and also it opens up the lower end better. And we'll show you some examples of that too. So the anatomy is important, Thomas. I think this is very important, but people don't realize that there's a common channel, and from the common channel you have bile duct and the pancreatic duct. And when you go up from below, you'll see it's only one channel, but as you go up, it separates out into two channels, and then when you go up further, it's a bile duct that is actually very prominent. So this anatomy is very important. But more than this, it's very important to look at it in a three-dimensional way. And if you actually look at this, is I think the most critical understanding of ERCP is to understand that the lower end of the bile duct comes up like this, goes up, and then takes a horizontal path and then goes up. This S-shaped one is what makes all the cannulation difficult, and this is very important to realize. Whereas the pancreatic duct is direct, so most of the times you're cannulating the pancreatic duct very easily because you don't have to go through this path.
And if you poke around, it even makes the S shape worse.
Yeah, if you poke around too much, in fact, what happens also is you can actually go through the papilla and come out on the opposite side and produce a fistula on the papilla.
Okay.
So this can be a problem. The other important thing is, if you look at the bile duct, it's also important to look at it in a three-dimensional way, that it's just not the S-shaped, but also it turns a little to the right as you go up. So when you're actually going through, you have to turn your body slightly towards the right, so it's going away to that side. So these are the two subtle important
I sometimes think I would like, in difficult cases, an even softer tip of the guide wire.
I think the guide wire, again, we show you this, the guide wire that we use is this. You can see I use a hydrophilic wire, and again, it's important that the wire, you can see how you can manipulate the wire. See what happens when you twist the wire. Always angulated wire for first cannulation. You can actually see that the wire twists and goes to whatever side you want to. And this is very clearly illustrated in this. You can see the wire is going to the pancreatic duct all the time. You come back and you twist the wire in anti-clockwise position. When you do it in anti-clockwise position, the wire then slips up to the bile duct. So this is very important to understand, and so that's the reason why we prefer a soft hydrophilic wire, which then can be manipulated by the assistant. We tend to use shorter wires, 280, so that the assistant easily manipulates it. But if you are using the longer wire, there is wire guide twisters available with which you can twist the screw. You can use that, or sometimes you can do it with your hand, but better to use something to twist it easily. But with short wire, this is very, see the amount of range of the twist it's got. And you can, this again, you can illustrate it here. See, these folds make it sometimes very difficult, and the wire is tending to go into the pancreatic duct. And what we have to do is to see that you come back again. Of course, again, when you go into pancreatic duct, you always go with a loop so that it doesn't cause injury. The software also helps. And you can see a little twisting here can allow us to go into the bile duct. So I think this is very important, so that the wire what you use it should be, in my opinion, an angled hydrophilic wire that we use first.
And you do it with an assistant, because there are some people who want to do everything by themselves, and they.
Yeah, there is, I think, two schools of how ERCP cannulation is done. One school is a single-handed with one person doing everything, because most of these accessories have come now where you can pass the wire through and you don't have to have a whole wire outside. This is okay if you don't have good assistants, but if you have good trained assistants, we prefer the long wire. And many centers in Asia still prefer the long wire because the assistant is actually doing the manipulation. So this is again very important, that when you approach the papilla, you have to decide which duct you want first, the bile duct or the pancreatic duct. And you can see from these illustrations that when we want the bile duct, we want to go at 11 o'clock position or 12 o'clock position as the first touch. If you want the pancreatic duct, you go at about 2 o'clock position. Sometimes as a clue is that the small pouting tissue at 11, 12 o'clock, and this is the tissue where you should aim your catheter when you're trying to get into the bile duct. So I think, Thomas, the important thing is not to immediately jab, but just observe your papilla for some period of time. When you observe your papilla for a period of time, you get to know, in fact, the papilla becomes much more prominent. You can see it better if you're watching it for some more time rather than immediately jabbing it.
And this direction thing is, so you look for the orifice, and then from the orifice you go leftish upwards for the bile duct, and rightish.
So, of course, this is a famous illustration which came long back from Peter Cordonier. This is very cartoonist, but some little practical truth in this. So, when you're going to the bile duct, you're going right on the top there at around 11 o'clock, actually bending your sphincterotome, bending it. And then as you go a little deep inside, you release the sphincterotome and pull your scope up. You can see this in the second cartoon here. And then finally, when you pull it up completely, the whole sphincterotome slips inside. So you start in 11, 12 o'clock in a very low down position, pull your scope up like this, and as you do that, the sphincterotome slips inside. You can see it in the subsequent video how this is done. Subsequently, it's been named the shoehorn procedure. How you actually put on your shoehorn, you do the same procedure.
And the diameter of the guide wire is smaller better, or doesn't it matter?
We used to do with 035, now we switched to 025. I think in ERCP, there is very little role for 035 wires now. 025s are stiff enough. They have good hydrophilic ends. We use the ones which have a long hydrophilic component. I think we should switch on to 025 because they move better in the catheters. And to show you this shoehorn technique, the actual movement what I described just now, you see how we are starting with very low down, and then we pull the scope up and then push it back down again. So you cover this S-shaped phenomena, and this is something very important for people who are starting ERCP to learn the shoehorn mentally, that you start from below, push the scope up and then pull it back again. So this will straighten the S-shape so that your catheter goes inside. I think that's an important, mentally one has to get used to this thinking. And I can actually show this on a video. You can see both the cartoon here on the left side, and you can see the actual procedure. How we go down, see first you're actually bending it going from below, and then turn your scope, you turn your body towards the right a little, that you adjust it, and then you pull the scope back and then push it down again, see that, and then it goes inside. So if you do this maneuver, it's very often that you don't fail getting into the bile duct. So this is a few little small tricks.
Is it important to have a rotatable sphincterotome or not?
No. I think rotatable sphincterotome has a very little role. The only indication I use rotatable sphincterotome is you have a papilla which is abnormally. Sometimes you have congenially a papilla which is down on the left side, doesn't come into position. Rarely or post-surgical I've used rotatable. But I think in general, rotatable sphincterotomes have very little value when you're actually cannulating. Occasionally when you're cutting, sometimes your sphincterotomy wire is going all the time into the right. Then you can correct it by rotating it. That's the only indication there.
And the diameter of the sphincterotome is smaller better as well?
No, I think they're all standard, starting with 5 French at the tip, going up to 7 French when you're actually pushing it. So it's standardized. Very rarely for very small papillas, and this again, we can use a wire-guided cannula. You can see here this papillary orifice is very small. A spinotome won't go through. So what we're doing is putting the wire outside, and then after passing the wire inside, follow it with the spinotome. And then what happens is once you're a little inside, you can adjust your wire whether you want to go into the bile duct or into the pancreatic duct. So
yeah, that's also important. That because in most examples you showed the sphincterotome tip and then the guide wire comes.
Yes, yes.
But you could also have the guide wire exit a little bit and use it as a prolonged sphincterotome with a very small or thin tip.
Yeah. So then, so this is usually for papillas which are very small, or even for the axillary papilla. When you want to cannulate the axillary papilla, we always use the guide wire technique first because the sphincterotomes are too big for that.
Mm-hmm. Yeah. And changing back to a catheter, which you bend, is that if you fail with a sphincterotome?
No, I very rarely fail. When I fail with a regular cannulation, I would then go to do an advanced, so-called advanced cannulation techniques, which would be anything from double wire, guide wire to putting a pancreatic stent to cannulation to needle knife sphincterotomy. So I'd go to one of these three procedures. Changing from a sphincterotome to a standard catheter is not going to help.
So you think a catheter is not helpful. So what do? You have an optimal sphincterotome, a very nice guide wire, but you can't get in.
Yeah. So I'll show you a technique where you can see here the guide wire is inside the sphincterotome, but not able to get in. So what then I want to do is inject small amount of contrast and see how this contrast goes in. It goes in like this and then comes back. And then when you do that, the guide wire then goes in easily. So injecting small amount of, so when you talk about guide wire versus cannulation with injecting, you can see this is small amount of injection. So it's a combination technique. I've injected small amount. So I know the pathway of here, it's going like this, and then my guide wire can then be following this pathway. So I think this is another technique where small amount of contrast followed by, it's not defined in the literature well, nobody has sort of described this well, but that helps in your cannulation.
So it's like flushing the orifice open?
Exactly.
Like in the colon, you flush when you want to get around the curve?
So it's like flushing it open and also following that pathway.
Would you ever think, I mean, there are some people saying if we have mini cholangioscopes, we would find the way, or do you think?
So this is, I think there's now a certain amount of tendency to try and see if we can do fluoroscopy-free cannulation, remove the stones and all. But I think the problem here is that the present cholangioscopes that we have are very stiff. They can cause more problem. We can't find a pathway with this because when you go with a cholangioscope into the common channel, everything is collapsed. You can't see anything. But there are now new 7 French cholangioscopes which are coming, which may become in the future a technique of selective cannulation.
Whether this prevents pancreatitis to a higher degree, we don't know, or the contrary.
The initial RCT has shown that it doesn't cause increased pancreatitis, but I think this was an expert hand, so we had to look at it in everybody doing it. Yeah.
So that's kind of a next step technique to inject a little bit at this stage, not primarily. That's what you are doing.
So we primarily try the shoehorn technique, get in with the sphincterotome and the guide wire. If that fails, I don't want to push the guide wire too much because that can produce trauma. Then I inject small amount of contrast and follow it up.
Okay. So Nagi, thank you very much. These were the basics. Yeah. That's our first episode on ERCP cannulation. We're coming back with the next one in the next episode. Thank you.